Finals SAQ 94, Rib Fracture Pain Control. You are called to the emergency department to assess a 63-year-old man with known chronic respiratory disease. He has sustained unilateral fractures to his 9th, 10th and 11th ribs, but has no other injuries. Paracetamol and codeine phosphate have not provided adequate pain relief. A. What respiratory problems could result from inadequate pain relief in this patient? This includes respiratory depression, vasoatelectasis, VQ mismatch, poor oxygenation, respiratory failure, failure of secretion clearance and pneumonia. B. How can the effectiveness of his pain relief be assessed? Via pain scores, either visual analog scores or matching face to pain. Intervals between assessments should be as short as 15 minutes until good pain control has been achieved, and then less frequently. Assess pain at rest, on movement, deep breathing, coughing, on incentive spirometry, and ability to comply with respiratory physiotherapy. Other physiological parameters should be assessed. This includes heart rate, respiratory rate, and blood pressure. Assess frequency of use of breakthrough pain medication, and involve pain team to facilitate regular assessment. C. What other methods are available to improve management of this patient's pain? This includes oral analgesia. Ensure paracetamol and codeine are administered regularly with the maximum appropriate codeine dose for the patient. Consider NSAIDs after ruling out contraindications. If codeine is insufficient, change to a stronger opioid such as oral morphine. PCA morphine or fentanyl are options, but monitor for compromised respiratory function. Topical option includes local anesthesia patches. Regional block options includes thoracic epidural, thoracic paravertebral block or catheter, intercostal block or catheter, and serratus anterior block or catheter. All regional anesthetic techniques for rib fracture analgesia interrupt pain transmission at various points along the intercostal nerve. Surgical option includes operative fixation. Overall 43.7% pass rate. Further information: NHS Rib Fracture Management Guidelines 2025. Rib fractures compromise ventilation via pain, leading to above-mentioned complications. Opioid analgesia respiratory depression effects. Flail chest and hemo or pneumothorax. For all patients, if pain is uncontrolled, titrate IV strong opioid to effect. Calculate rib fracture score to determine initial management. Consider early regional anesthesia if unable to do all three of taking a deep breath, cough and mobilize. Have low threshold for regional analgesia in patients who smoke or have underlying lung disease. Components of the rib fracture score includes number of breaks, sites, and age. If RFS is 3 to 6, provide regular paracetamol, NSAIDs if not contraindicated, weak opioids, oral strong opioid as required. Provide laxatives and antiemetics for patients on opioid analgesia. Refer ICU if SpO2 less than 94% or on FiO2 more than 40%, and chest physiotherapy if significant other injuries. If RFS is 7 to 10, change the weak opioid to oral strong opioid. If RFS is 11 to 15, change oral strong opioid to patient-controlled analgesia. If RFS is more than 15, refer for regional anesthesia. Patients with features of neuropathic pain, such as burning, tingling, electric shock-like sensations, or numbness, should be prescribed a gabapentinoid. Assess adequacy of analgesia at least every 4 hours. If inadequate, obtain medical review for optimization of analgesia. Regarding paracetamol, for patients under 50 kg, reduce dose to 15 mg per kg. For NSAIDs, avoid in renal impairment, current or previous GI ulceration, active bleeding, severe liver disease or heart failure. For strong opioids, avoid in frailty or renal impairment. In patients aged 65 or more, ibuprofen should be omitted and regular opioid changed to oxycodone, which has a better pharmacokinetic profile for the elderly. In patients with eGFR less than 30, ibuprofen should be omitted and oxycodone dose reduced. For those with renal impairment or frailty, avoid NSAIDs, oxycodone immediate release, 2 mg 4 times daily, plus 2 mg when required, maximum 4 hourly. Refer acute pain team or anesthetic registrar if pain is uncontrolled. Regarding regional analgesia, indications includes for age less than 65 years old, 4 or more fractured ribs. For age more than 65 years old, 3 or more fractured ribs. Presence of flail segment, uncontrolled pain not responding to conventional analgesia, unacceptable side effects from systemic analgesia and/or worsening respiratory function, and in any patient with chronic pain or yellow flags. Pain yellow flags refers to factors that increase acute pain and predispose to chronic pain. This includes history of chronic pain of more than 3 months duration, history of long-term opioids, 60 mg oral morphine or more equivalent daily, including patches and lozenges, history of long-term intake of neuropathic pain agents, such as gabapentinoids, tricyclic antidepressants, such as amitriptyline, and SNRI, such as duloxetine, history of severe anxiety, depression, or adverse childhood experiences, history of substance abuse, including opioids or benzos, or participation in opioid replacement programs such as methadone or buprenorphine. Contraindications to epidural analgesia includes absolute contraindications, patient refusal, spinal cord injury or hematoma, epidural hematoma, thoracic vertebral body fracture at level of insertion, local or generalized sepsis, open wound at site of insertion. Relative contraindications includes unable to position patient, traumatic brain injury with uncontrolled ICP, incomplete spinal evaluation, previous thoracic spinal surgery, coagulopathy, active anticoagulant therapy, and extubation not anticipated within 5 days. Start items apply to regional blocks. Examples of goals includes for patients to leave the emergency department with pain score less than 5, to instate regional analgesia within 6 hours of referral if conventional analgesic techniques did not reduce the pain score to less than 5. Any catheter-based techniques should be conducted in the theatre with strict asepsis. Additional points. This is a regional anesthesia decision aid for rib fracture management. For anterior or lateral fractures and patient unable to sit or roll, with spinal fractures or cervical collar or morbid obesity, option includes serratus anterior plane block. For posterior or lateral rib fractures, unilateral, and patient able to sit or roll to the side, options includes ESP block, best for posterior fractures, serratus anterior plane block, best for lateral fractures, ribs 3 to 9, or paravertebral or epidural, if poor effect from ESP or SAP. For bilateral fractures and able to sit or roll to the side, options includes thoracic epidural, or bilateral paravertebral, or bilateral ESP block, or bilateral SAPB. Discuss the role of regional analgesia in rib fractures or post-thoracotomy pain management. Benefits includes effective analgesia as part of multimodal analgesia regimen, opioid sparing effect, and avoidance of opioid side effects such as respiratory depression, sedation, nausea and vomiting, greater compliance to physiotherapy and deep breathing exercises, clearance of secretions, and better outcomes post-rib fracture. Cons includes needs a cooperative patient, may be contraindicated, difficulty in positioning, and hindrance from other injuries. This table lists the pros and cons of various regional analgesia options for rib fractures or thoracotomy, and is included here as additional information. Regarding surgical fixation, benefits includes stabilization of flail chest injuries, reduction in duration of mechanical ventilation, ICU stay, total hospital stay, hospital-acquired pneumonia and mortality. In the long term, patients return to work sooner and have a reduced incidence of chronic pain and analgesic dependence. Indications for surgical fixation includes flail chest with paradoxical breathing, multiple ribs 3 or more, displaced 100% or more, ventilated patients who have multiple rib fractures, thoracic spinal fractures with associated rib fractures, aka thoracic ring injury, failure of conservative or regional management for any number of rib fractures, and any that warrant discussion. These are my references. Thank you.